First talk. It's a pleasure for me to introduce Professor Fraz Mir, who is an Associate Professor of Medicine, Cambridge University Hospitals NHS Trust. He's also a Director of Studies, King's College, Cambridge, United Kingdom. He's a Pro-Proctor of the university. As Associate Dean for NHS, East of England, he has the responsibility for international recruitment and the Medical Training Initiative. From June 2013 to 2017, he was an Associate International Director for the Royal College of Physicians, London. He is an MRCP PACES examiner and a member of the MRCP Examiners Board. He will be talking to us about resistant hypertension.
Thank you for the introduction and good morning. Assalamu alaikum everyone. Very eye-opening and thought-provoking, certainly for me. And anyone following after him is going to be facing a big challenge. So thank you very much, Somia, for putting me through the test. I'm going to be talking about something very mundane, so resistant hypertension. So resistant hypertension is basically clinic blood pressure of more than 140/90, despite taking 3 antihypertensive drugs at optimum doses, and usually that includes a diuretic. Now, apparently in the UK, the incidence or prevalence is about 10 to 30%. The true prevalence is probably a lot lower, about 5%. In Pakistan, the only study I could find is from Karachi. In Karachi, in a tertiary care-based study of 515 people, they found that the prevalence of resistant hypertension was 12%. So just to explain why there's a discrepancy, I'm just going to go through a case. I'll try and make it interactive, so hopefully people are awake. So a 78-year-old woman who's obese with a history of hypertension, osteoarthritis and dementia, blood pressure 168 over 102, and the current prescription is as follows: candesartan 32 milligrams once a day, amlodipine 10 milligrams once a day, chlortalidone, which is a thiazide-like diuretic, 25 milligrams once a day, and also ibuprofen 400 milligrams 3 times a day for osteoarthritis. So my question to you is, what's your next step in management? I'm going to try and do an interactive poll if I can. So if you go to slido.com or use that QR code, you can vote for your preference. I'll give you a few minutes just to log on and see if you can answer. Hopefully this will work. Is it not working? I'm getting no responses. I'm not sure it's working. Well, should we have a show of hands? Who wants to go for bisoprolol? No one for bisoprolol. Doxazocin? A couple maybe. Minoxidil? Spironolactone? A few hands for spironolactone. Try something else. A few hands will try something else as well. So, a bit of a split. Okay, well, I'm sorry that didn't work. Oops, someone's gone for bisoprolol. One person voted. Well done. Right, so this is a trap. I'm sorry about that. Actually, the answer is probably try something else, and I'll explain to you why in a moment. So I think when you have someone with apparent resistant hypertension, there's 2 things you have to ask yourself. One is, do they actually have resistant hypertension, or do they have pseudo-resistance, i.e., are they actually taking their tablets? Do they have adherence to the medications? Or actually, are they measuring the blood pressure correctly? And I'll explain both of those elements in a minute. And the second question is, might they have an underlying secondary cause which is driving their high blood pressure? So let's take each of those in turn. So non-adherence in hypertension is very common. So this is just one study which looked at just under 5,000 patients on a single-dose treatment of an antihypertensive medication. And what you find is that by the end of about 3 months, only 2/3 of people are taking their tablets correctly. And actually the numbers drop off the longer the study is followed up. The problem with hypertension is most hypertension is asymptomatic, but the drugs we give people do have side effects, which means that adherence is often quite suboptimal. But actually, even in cancer trials, so these are people who are taking oral anti-cancer therapies for potential cure, even in those studies, adherence is about 2/3. So it's quite an interesting phenomenon. lots of psychology about why people do or don't take the treatments, but it's an interesting phenomenon that is replicated across most subject areas. So 2/3 of people only take the tablets. Now, one of the ways to check adherence is to use high-performance liquid chromatography and tandem mass spec. And what you do is you do a urine analysis, and you can send it for detection in the lab of drugs that people are on. So this is another patient who was resistantly hypertensive on a multitude of antihypertensive drugs. When we checked the urine, none of the drugs was detected. So this person was not taking the tablets. We looked at this in our clinic in Cambridge. We haven't published this yet, but it's in press. And what we found, again, just like the history-taking ideas and results, with urine analysis, only about 2/3 of people are actually taking the tablets. And actually, the more tablets people are prescribed, the more likely they are to be non-adherent. So adherence is a big problem. You may have noticed that this lady was on ibuprofen. Ibuprofen, like a number of drugs listed here, can actually make your blood pressure go higher. So ibuprofen inhibits prostaglandin in the kidneys, probably relating to salt and water retention. And as you'll recall, this lady was on ibuprofen, so you might want to stop her ibuprofen and think of alternatives whilst we're on drugs. Moving on to inaccuracies in blood pressure measurement. Now, we know that a lot of oscillometric devices are actually not very accurate. They differ by about 5 to 10 millimeters of mercury with the gold standard of mercury sphygmomanometers. There are also issues with cuff size, and I'll show you a graph for that in a minute, and also the difference between what is home readings or ambulatory readings or even ABPM readings versus what you find in the clinic. This is a slightly complicated graph, but I'll try and explain it to you. So we know that cuff size makes a difference in obese patients. If you use a normal cuff size in obese patients, so this is people in group 1, actually you will find more of them have hypertension in white than if you use a large cuff, where actually a lot more people don't have hypertension, they have normal blood pressure. So if you have someone who's obese with a circumference of more than 35 centimeters, you should be using a large cuff because it can make a significant difference. And it's the same for systolic or diastolic. Other inaccuracies, of course, are so-called white coat hypertension and the new phenomenon, or more recent phenomenon, of masked hypertension. So we don't wear white coats anymore, but the phenomenon of white coat hypertension is well described. And here's an ABPM showing you exactly that. So a patient who has high clinic pressures, but actually during the day, their blood pressure on the ABPM is pretty good. What we also know is that about 1/3 of people who have resistant hypertension, actually when you do an ABPM, their blood pressure is actually quite well controlled. So again, about 1/3 of people with apparent resistant hypertension actually do not have hypertension when you do an ABPM. Whilst we're on the subject, we know that home blood pressure monitoring, ambulatory blood pressure monitoring, unattended clinic monitoring are much superior than doing clinic blood pressures in terms of predicting cardiovascular outcomes. So home monitoring actually is a good way of empowering patients to take control of what their blood pressure is doing. And what I tend to recommend in my clinic is for them to do at least 5 or 7 days worth of twice daily readings. Take 3 readings each time. Always ignore the first reading, because with the oscillometric blood pressure monitors, it takes 1 reading for the cuff to sit in the right place. So always ignore the first reading, do the second or third reading, and take an average. I mentioned masked hypertension. So these are people who have normal clinic blood pressures, but when you do an ABPM, they're actually hypertensive during the day on the ABPM. The evidence is so far that we should actually be treating these people more aggressively, because a lot of these people end up getting substantive hypertension anyway. Another curiosity, inaccuracy to be aware of is pseudo-hypertension, as demonstrated by Osler's maneuver. This is something you find in people who are elderly with very heavily calcified or stiff arteries, those on renal replacement therapy, or those who are heavy smokers. So what happens is the brachial artery and the radial artery are very heavily calcified and stiff. So when you inflate the cuff with a sphygmomanometer, you do not compress the brachial artery, and therefore you can still palpate the radial artery because the artery hasn't been compressed above. So these people, although they look like they've got high blood pressure peripherally, if you check their central aortic pressure, actually the aortic pressure is much, much lower, and these people do not have hypertension. It's quite rare, but worth thinking about if you can palpate their arteries despite optimal inflation of the pressure cuff. So that's inaccuracies in blood pressure measurement. So adherence we've talked about, up to a third don't take the tablets. Up to a third of people with resistant hypertension will have normal blood pressure. So that's a lot of people already who actually do not have true high blood pressure. The second question to consider is secondary hypertension. And this is when you find an identifiable cause for why your blood pressure might be high. And if you identify it, then you might be able to cure it by tackling that specific problem, or at least it might make treatment much more directed and easier. Again, the estimate is about 5 to 10% of people who present to a clinic may have underlying secondary hypertension, but we're not really sure because it depends on what population you use. But 5 to 10% is a decent ballpark figure. This is a lecture in itself, but in terms of considering a secondary cause, you might look for certain pointers, you might look for features in the history. Do they have headaches, palpitation, sweating, etc.? Do they have muscle weakness suggestive of hypokalemia, high salt intake, drugs, etc., etc.? You may look for physical examination findings. I mean, if someone appears like this and has obvious features of acromegaly, for instance, then it's easy. They may have palpable kidneys, suggestive of polycystic kidney disease. They may have bruits, suggestive of femoral artery stenosis or coarctation, for instance. Investigations often may reveal cause in some people at least. So hypokalemia in particular is a finding that shouldn't really be ignored. And also renal dysfunction can often be a cause that we find as well. And then, of course, you might look for secondary causes in those who have so-called accelerated or malignant hypertension, those who are quite young, and of course those who have resistant hypertension. I'm just going to pick out a couple of these causes. So Conn syndrome, or what it's now called primary aldosteronism, is probably a lot commoner than we think. So this is the original paper from about 70 years ago by Conn and Louis, which showed the classical biochemical features of hypernatremia, hypokalemia, and metabolic alkalosis. Now, until recently, until about 10 years ago, we thought that primary aldosteronism was quite rare and probably responsible for only maybe about 1% of hypertension. However, now we think it's probably the commonest cause of adult secondary hypertension. So in unselected patients, maybe up to 8 to 12% of people may have primary aldosteronism. And in people who come to clinic with resistant hypertension, it may be up to 1 in 4. The problem is that often primary aldosteronism is masked by drug therapy. So if you're on a beta blocker, it will inhibit renin secretion anyway, so it can muck around with the results. Calcium channel blockers can inhibit aldosterone secretion. And of course, you may be on other drugs, which makes it difficult. Only about 40% of people with primary aldosteronism have hypokalemia at presentation, so it's not an easy diagnosis to make. And what we now also know is that there's a spectrum of disease. So you may have the pure adrenal adenoma suggestive of Conn's tumors, but you can also have micronodules, you can also have hyperplasia, etc., etc. So there's a whole spectrum of disease. When might you operate on someone with primary aldosteronism? Well, in our clinic, we tend to ask and ensure that there are 4 points that we fulfill. One is a biochemical abnormality of a suppressed renin and also of a low potassium, if possible. Then do some cross-sectional imaging, either an MRI scan or CT, or maybe even endoscopic ultrasound. Confirm adrenal vein sampling, so it should lateralize to the same side. And then try and see if they have a response to aldosterone antagonists like spironolactone or eplerenone. If they fulfill those criteria, the evidence is that you may offer cure in up to 50% of people with primary aldosteronism. A Conn's tumor is very lipid-rich, and this is what it looks like when you cut it. It is never a malignant, it's a benign tumor, so actually in elderly people, you may just consider medical management rather than consider surgery. Always important to mention pheochromocytomas, quite rare, maybe up to 1% of people with hypertension. We're seeing them more and more because a lot more people are having CT scans for other reasons, and a lot of people now are finding that they've got incidentalomas on CT scan, and about 5% of those may actually turn out to be pheochromocytomas. The reason not to miss pheos is A, that they can cause catastrophic crises, which of course should be managed with alpha blockade preferentially, but also they can be malignant in up to 10 to 12% of people. So it's worth checking them out for pheos with plasma metanephrines or urine metanephrines if they have a history suggestive of pheos, so the sweats, the tachycardias, the headaches, etc. You don't always need fancy scans to diagnose secondary causes. So these are people with chest radiographs. So if you look carefully, you can see rib notching here, suggestive of big collaterals due to coarctation. And also here you have the 3 sign, which is due to the stenosis causing the pre-stenotic dilatation and also the post-stenotic dilatation. And you can confirm those with MRI scanning, and this is just one such example with a coarctation causing high blood pressure. The other vascular cause to remember is renal artery stenosis. Renal artery stenosis is predominantly 2 types. In older people who are smokers, it's often related to atherosclerosis, and actually the evidence is angioplasty is probably not very beneficial unless they have very severe problems. But actually where it is curable potentially is in younger people who have fibromuscular dysplasia as the cause of the renal artery stenosis. And in those people, angioplasty can be curative. These are often young women. Okay, so let's go back to our patient. So she's got the blood pressure of 168 over 102. She's on these tablets. We've done all the things that I suggested. So she's taking a medication. She's adherent to all of them. But she's now stopped the NSAID and she started physio. Her ABPM does confirm that she is significantly hypertensive. She uses a large cuff, and there's no evidence of underlying secondary cause. So the question is, what do you do now? Well, you could make another push for lifestyle modifications. We know they make a difference. The problem is people do not adhere to them. So Mrs. Snowman has lost a husband because he takes too much salt. And of course, this gentleman wants to keep in shape, which is a problem. But joking aside, lifestyle modifications do make a difference. So if you add up weight reduction, eating healthily, dietary sodium reduction, physical activity, not smoking, etc., then actually, you can get a blood pressure reduction of up to 20 millimeters of mercury, which is equivalent to what you would get with one therapy for blood pressure. So it's definitely worth reiterating every time. Once you've done all that, you next got to move on to pharmacological therapy. So the current British guidelines are you start at step 1 for high blood pressure with either an ACE inhibitor or ARB or a calcium channel blocker. You add both of them in step 2, and in step 3 you add in a thiazide-like diuretic. And then you come to the resistant hypertensives at step 4, and the question is, what do you add next? So the options would have been alpha blockers, spironolactone, or beta blocker. And actually we have a good trial now which answers that question, and this was the Pathway study, which showed quite clearly that in those people, spironolactone at low dose is superior to doxazicin or bisoprolol. And that's what you tend to sort of use a lot more of in people with resistant hypertension nowadays. The issues with spironolactone are it can cause gynecomastia in men. They don't like it. It can also cause impotence. So actually you can use amiloride or even eplerenone as an alternative option. They both work equally as well. And thereafter, you can look at physiological targeted approach, like, for instance, measuring plasma renin, which is what we do in our clinic. So if they have a high renin, you might want to use a beta blocker, because beta blockers inhibit renin secretion. If they have a low renin, you might want to give them more diuretic to help offload the salt and water, which is probably suppressing the renin. And somewhere in between, you might add in doxazicin as the 5th agent. Failing all that, there's always minoxidil. The problem with minoxidil is it can cause hirsutism, it can cause fluid overload and tachycardia, which means that they have to take beta blockers and diuretics in addition, which again then may drive non-adherence. So that's a problem. Once you've exhausted all pharmacological therapies, are there other options? Well, there are device therapies that are now available and are quite fashionable, certainly in the Western countries. So the most well-researched and perhaps the most efficacious is renal sympathetic nerve ablation, where you pass a catheter into the renal arteries and you basically burn the sympathetic nerve. That can result in a good blood pressure reduction, and it can be long-term. So there was a recent systematic meta-analysis, in fact systematic review done just last couple of weeks ago, which showed that it's about 13 millimeters of blood pressure reduction in those with resistant hypertension. Other options are formation of AV fistulae. This is where you actually make an AV fistula using a device, so it's quite invasive. It does help, but like I say, it's pretty invasive. And the other thing is carotid body stimulators, whereby you stimulate carotid output, so you inhibit sympathetic drive, and that lowers blood pressure. But this is quite a horrendous-looking tool, which you sort of implant into the neck, basically. Just a word of warning about devices in general. The regulatory burden of evidence on safety and efficacy is much lower for devices than it is for pharmacological therapies. That's the first thing to say. And the second thing to say is that the placebo effect is much more powerful for devices, so just be mindful of that. So just to finish, I'm going to slightly tweak the case. So still a 78-year-old woman, but a very long history of high blood pressure, still quite hypertensive. By now, she's on 6 drugs. She's taking all of them. So she has refractory hypertension. If you're on more than 5 drugs, it's called refractory, just a nomenclature. So my question this time is, could we have intervened earlier? This is a graphic taken from a paper in circulation a few years ago now, and it highlights 2 adages. One is prevention is better than cure, and the second thing is that hypertension begets hypertension. So the problem is, if you start with a high blood pressure, even at a young age, you would then go on to develop high blood pressure later on when you're older. It's not surprising. It doesn't suddenly happen. So if you look at these people who have resistant hypertension at the age of 50 or 60, often they will have had high blood pressure even from very young ages. So the idea is that actually if you intervene much, much sooner and more aggressively in young people, then maybe they can follow this trajectory rather than this one. So just to finish then, some key points. If you have someone with resistant hypertension, do check for pseudo-resistance. Are they taking the tablets? Are they measuring blood pressure properly? Do they have white coat hypertension? Exclude secondary causes, reiterate lifestyle interventions, and actually when it comes to newer pharmacological therapy at stage 4, spironolactone is probably the best option. Device therapies are in the research phase, but renal denervation may be the best sort of option in selected cases. And I think the final point to mention, which I haven't really talked about, is don't forget other cardiovascular risk factors too, so lipids, diabetes, etc. Before you put them on the 6th or 7th drug, please make sure that you're tackling those things adequately too. I will stop there. Thank you ever so much for your attention.